The first and our next speaker is Jane Kaye. She's professor at the University of Oxford, and she is the leader of the Center for Law, Ethics and Emerging Technologies, and she's going to address the ethical issues around personalized medicine. I'm very happy that you're here, Jane. Thank you.
While the slides are coming up, I'd just like to thank the organisers for inviting me and to thank all of you for being here, and particularly to Lord Brennan, distinguished guests and colleagues. I'd like to start talking about a model that we're developing at the University of Oxford in conjunction with the Oxford University Hospital Trust, which is looking at the ways that we can fast-track personal medicine. And it's a model that is focused on embedding a biobank within the healthcare structure that can be used for both research purposes as well as clinical purposes. And we're using a dynamic consent model. And it's very much about aligning existing systems and using those who come into the hospital, seeing them as a cohort that we can track over time. And there will be benefits for them as well as for research. So I think it's fairly uncontroversial that personalised medicine is grounded in genomics, but it's also about the individual and how we can start to develop care that is tailored towards individual. So this is an artist's representation of James Watson's, it's a portrait of James Watson, who, as you know, actually identified the helix structure. And it's a portrait using his base pairs to actually make his portrait define. But the important thing about personalised medicine is that it's actually putting people at the centre and very much aiming at tailored care. And so when we were developing our dynamic consent model, we very much focused on the ways that we could develop an IT mechanism that would put individuals at the centre and think about their needs. But personalised medicine also requires large numbers of people, and it requires people to come together and for their information to be used in new ways. So it's about individuals, but it also requires large data sets and also large numbers of different kinds of samples. And so this is why we are working towards a system where we can actually pull together all of the sample collection that happens as part of routine care. But as you are well aware, and I don't really need to tell this audience this, but we have certain ethical and legal requirements that are found in civil society. So, for instance, we have a requirement from the Convention of Human Rights and Biomedicine that, in actual fact, the people should give a voluntary, informed consent before they become involved in medical research. Now, there's a number of exceptions to that for different kinds of research, as people will be aware of. We also have Article 8, the right to privacy under human rights, that requires that individuals' privacy should be respected and that the state can only interfere with that if it is proportionate and justified and according to law. But we also have information law, data protection principles that require that individuals are informed or know about how their personal information is used. So we have a very clear legal framework, and there are a number of exceptions within that, but it actually puts the individual at the centre and allows and actually puts in a number of protections for them. Alongside that, we have our ethical frameworks, our research ethics committees, our governance and supervisory bodies that also maintain those standards. So when we were thinking about developing our dynamic consent model, we had to consider this framework when we were developing an IT mechanism that placed individuals at the centre of decision making. So our dynamic consent model came out of a project which was a collaboration between between academics and industry, and the idea behind it was that the control of information should be as easy as turning on and off a tap. And one of our case studies was a biobank. And this started this whole process of thinking and about how we would enable people to give consent to the use of information and samples, but also to be able to withdraw that consent. So we started with the Oxford Radcliffe Biobank based at it was the John Radcliffe Hospital at that point, and we started to work with them about how we could develop this interface. So the model that I'm going to describe now is one that is in the process of coming together. We haven't actually, like Nona Paul, got the great stick which will solve everything, but it's very much a prototype. But it's based on public and patient engagement and embedding this process within the new Oxford University Hospitals Trust. So basically, it is aimed at having an engagement strategy so that patients are aware of how information is being used within clinical care, within the hospital, but also for research purposes. So as you can see from this diagram, people can get involved through this mechanism, whether they come through a clinic, whether they come through research projects, whether they come through a clinical trial. And that is all of the individual interactions are based in a program of public engagement that actually is around the hospital, but also within our local community. So we have established the Oxford Bioresource, which is a combination of information as well as samples. And as I say, the aim is to actually link that to electronic records, but at the moment we're starting small, we're starting with the samples. And what our dynamic consent model enables people to do is actually have a portal where they can actually choose how they get involved. So individuals who want to know about every use of their sample can actually find that out, and they can ensure that people go back to them for their permission for new types of use. But also it enables you to actually give a broad consent to the use of tissue for medical research, for instance. So our dynamic consent happens over time, and that's why it's dynamic. Effectively, it provides a portal for communication and interaction so that you can go back to people, you can ask their opinion, you can get their consent about how their information will be used. And then by the use of a sticky policy, an IT mechanism, basically those consents travel with the samples. And if the individual changes their preferences, that also changes with the sticky policy. So that whenever you use a sample, you know exactly what the consent is that attaches to it. But also, this allows industry, clinicians and academics to access the information in the biorepository or the samples. And for research purpose, this can lead to research findings. But it also means that information can be fed back. But all of this is done with dynamic consent. So every time the individual can set their preferences or be approached for the use of tissue and data. And this is fed back so that data surplus samples know-how can go back into the biorepository. And the aim is that by using this collection of information and samples, you can use it for research purposes, but also for clinical care. So it is a resource for personalised medicine. So what are the benefits of the dynamic consent model? Firstly, it ensures conformity with legal and ethical requirements nationally and globally, because consent is a global requirement for most forms of research. But it can also be used to streamline recruitment, consent and reconsent processes, because of course this is a huge issue, but also the potential to feedback research findings through the clinical pathway. It means that recruitment costs are lower, and this is a huge issue, as many of you will be aware. It leads to greater accountability and research integrity. And also, once we have yet to get this approved by a research ethics committee, but the aim is that having this authentication or this accreditation means that we can move away, or we can supplement the research ethics committee application procedure. So, what does it mean for patients? It means that they have an opportunity to have greater control over the use of their information if they so desire over time, but also they can opt out. So they can say, I'm delegating this to a research ethics committee or some other body that will make decisions on my behalf. But then they have the opportunity to go back at a later time and actually change those preferences. So this is about an ongoing relationship with individuals for people who come through our hospital. They can become active partners in the research process, so moving more to the patients like me model, Cure Together, that we start to collect information from the people where things are happening inside them. That all of that valuable information about people's experience of using drugs, of dealing with their conditions, can actually be captured in a way that we haven't been able to do before. It also means that research ethics committees or researchers who are often forced to actually make a judgment in difficult or new situations don't have to stand in the shoes of participants. You can go back to participants and ask their opinion. It also means that you have an ongoing interaction and communication in real time. And of course, this means that it actually changes the relationship between patients and professionals. It also has the potential to enhance confidence and trust in the system. So in conclusion, what does dynamic consent do? It places participants at the centre of decision making about their samples and information. It enables ongoing communication and interaction for clinical care as well as for research. It means that you can actually record all consents and interactions in one place, but I'm sure that all of you here can imagine other uses that you might have of if you can actually have a portal that enables patients to receive information or research participants to receive more information. But also, most importantly for me, it ensures conformity with regulatory requirements that have been developed over many years and which we must really be vigilant about protecting. So thank you.